Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. The information is not to be interpreted as or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, or treatment. Welcome to this week's episode of the Dutch Podcast. My guest today is Dr. Lara Briden. She's a naturopathic doctor and former evolutionary biology researcher who has really studied the impact of hormones in women's health and looks at it from a really unique perspective. Today, we're going to talk all about the menstrual cycle, why access to our own production of hormones is so critical for our health, both our short-term health and our long-term health, with conditions like osteoporosis and metabolic health. And really, Dr. Briden has a really unique perspective as an evolutionary biologist, really understanding why it's so important to be cycling, why it's so important to understand your cycle and improve your hormone literacy, and even why women live this long lifespan past menopause. It's only humans and killer whales, I think, that live that long and go through a menopause. But she really does talk about why that's so important for our species and why we evolved that way. She's a wonderful guest. Dr. Briden brings an extensive amount of background, 3 decades of clinical experience in women's health, and really she's been completely focused on menstrual, hormonal, and metabolic issues with that integrative and naturopathic approach. She's authored 3 best-selling books: The Period Repair Manual, The Hormone Repair Manual, and Metabolism Repair for Women. She currently resides and consults in Christchurch, New Zealand, and she's on several advisory boards, editorial boards, all focused around women's health, research, and education. I'm really excited to get started. Let's go ahead and dive in. So, Lara, I'm really excited to have you here on the Dutch Podcast today. Thank you so much for being here.
Thanks so much for having me.
I always like to start, because we speak with such interesting people with this connection to integrative and functional medicine, and you're trained as a naturopathic doctor, as myself. But can you share a little bit about what brought you here? Like, how did you get to this place where you're a naturopathic doctor focused on women's health? Our listeners love to get to know our guests like this.
Yeah. So actually, a big part of my backstory is that before I trained as a naturopathic doctor in Canada, I was trained as and working as an evolutionary biologist. And I even published a peer-reviewed paper like more than 30 years ago on sex differences in foraging behavior in animals. So I was always, looking back, I was always so interested in female physiology. I sort of had a recent opportunity to go back and read some of, not just my published paper, but some of the university papers I was doing. And I was like, wow, I was just right from the beginning, like in this process of framing female physiology as kind of the standard normal version of mammal physiology, and males, the kind of quirky variant. And of course, I brought that into work as in health, because as you know, I mean, a big thing that's happened over the last forever really is that, male physiology has sort of been the normal, and then women are considered different only in terms of periods or breasts or just a few things, but actually we're different at every level, like every cell. So it's just a never-ending source of fascination for me. I'm very curious about biology, which I think has driven my work. I'm also very curious about people's stories. So I still do some patient work, even though I don't do that full time anymore because I just can't. But I love, like later today, actually, I have a full day with patients just to sit there and listen to their stories and their questions. And yeah.
Have you read Lucy Cook's book? It just came out last year. It's called, I have to, they're gonna have to bleep this out, but the book is called Bitch. But it's she's an evolutionary biologist, and it's all about like female species and how kind of a merge. This is like such an off-topic aside, but I think you probably really love it. She's really funny of an author, but it's probably a lot of the things that you studied. But it's talking about like evolution of the female species, and actually, evolutionarily, they believe that females kind of came first before males, which is so interesting. And then, this is what she explains in one of her book, and then she talks about all of the ways that females are thought to be
culturally like less aggressive, or they are the ones who are pursued. And she goes through species by species, all these anomalies. It's really, really fascinating. You'd probably enjoy it. It came out last year.
Yeah, I think I have heard of it. I've read some other, yeah, no, there's some other sort of similar books that came out around the same time, but I will definitely check that out. And
Yeah,
it's
just on
true.
the side.
Yeah, I mean, women are not passive. We have our own aggressive tendencies. There's actually, I mean, there's actually quite a lot of, within women, a lot of kind of between women competition, which is we don't like to talk about because we love to think that we have this, sisterhood. But yeah, there's some dark aspects.
Yeah,
Anytime you start looking at biology, there's always some things that we don't want to
that's
see,
right.
we don't want to know
Yeah. Well, I
about.
know this is like not the topic of
Yeah.
the reason why we brought you on today. We want to talk
No.
about periods and hormones
Yeah,
and all this great stuff.
of course.
But
Yeah.
I really appreciate that background that you came from, because it's
Hmm.
really it helps you understand kind of where we are today biologically and why things are the way they are, and even some of the like the competition that you speak of, how that serves us in some ways and how other
Yeah.
times it doesn't. I think when you look at it from like evolutionary biology and anthropology, you can see patterns that really matter even on the individual patient level.
There's this great quote, and I've forgotten who it's by, but it's quite famous. People could look it up. It's called "Nothing in biology makes sense except through the light of evolution, through the lens of evolution." And that's true for health as well, I would say. I've been, for a number of years, I was a member of a evolutionary health society here in New Zealand. We were a group of doctors and nutritionists and scientists and other, clinicians, just all, compiling our knowledge into seeing health in that way. And yeah, I found it very meaningful.
That's great.
Hmm.
Well, I want to start with the importance of understanding our hormones. You use the term hormone literacy, and why women really need to understand what's happening hormonally. Can we just start there, and can you talk about why this is such a passion for you?
Yeah. Well, the original term, I mean, hormone literacy has a nice ring to it as well. There's an older term called body literacy, which came out of the fertility awareness area based methods. It was actually coined by a Canadian friend of mine, Lara Briden. And body literacy is knowing if and when you ovulate, which is very foundational, because a lot of women today a lot of women do know. Certainly there's a lot of women who are very keen on tracking cycles, and hopefully, the naturopathic doctors listening to this are all over that. But more broadly, in terms of many doctors and certainly scientists and journalists, ovulation has not been on the radar as something as central as it is. Because just to put it bluntly, regular ovulation is how women make hormones. So at the end of the day, we make estradiol, our main ovarian estrogen, on the way to ovulation. We need to be progressing to ovulation to actually get that proper pre-ovulatory peak of estradiol. And then obviously the only way to make progesterone is to ovulate. And that is just a foundational piece of human female physiology that has unfortunately been largely left out. And one of the ways that it's been left out, it's impossible to talk about ovulation and how important it is for general health, not just for making a baby, but it's impossible to talk about that without talking about the era of contraceptive medication that we've just come through, that we're still in, although I think we're in the tail end of it now, where it has been considered fine and normal to routinely switch off ovulation. So switch off the hormonal system of hundreds of millions of women, including young girls, and just there's been a lot of wishful thinking, kind of going, oh, that'll be, it's going to be fine. It'll be good enough. We're going to switch off estradiol and progesterone, which, as you know, have very specific effects in the body. And we're going to replace those with ethinyl estradiol, a synthetic estrogen, which is actually kind of like estradiol, and then plus one of many progestins, which are so different from progesterone that it's just heartbreaking, actually, just the difference in all sorts of things. I mean, real progesterone has benefits well and beyond preparing the body for pregnancy. It obviously affects the brain. It converts to a really fascinating neurosteroid called allopregnanolone, which no progestin does. Real progesterone is very important for bone health, which I know we're going to touch on today. It's an immune modulator. It's like Yeah, and women, for
Yeah.
generations, we've been robbed of it collectively.
We were actually on our education team meeting today, a bunch of doctors talking about how we should be developing allopregnanolone as like an OTC drug. You can just go in the store and get it to get all the benefits of that progesterone metabolite because it is so potent. It's funny that you bring it up today.
Yeah. Well, it is very important. And actually, as you probably know, you might have even talked about it in your meeting, there's a number of scientific papers using progesterone and therefore its metabolite allopregnanolone for traumatic brain injury in both sexes, actually. So it's that important for the brain that it is on the radar as a brain medicine.
Yeah, I've learned that actually Paul Anderson teaches that for TBI, like in men, but a lot of the cases he works with are in men. And
Yeah.
it's quite high dose, but really
Yeah.
amazing
Yeah.
outcomes. Yeah. So when you look at like women, oftentimes, one, they don't know a lot about their menstrual cycle or about ovulation. And, I hope that that's changing. But I think the foundational education, I think it's actually social media and kind of consumer driven education versus like a systematic process. And I think, there used to be women used to live with other women. I think they probably got that in more of a handed down generational
Yeah.
training or education. It's not translated to like our school systems as effectively. It's really more sex education versus menstrual cycle and hormone education. I love your thoughts on that.
Yeah. Well, exactly. I mean, if you think about how revolutionary would it be to teach girls that ovulation is how you make hormones, that developing, by developing, I mean maturing into a healthy, regular, natural menstrual cycle is going to make you healthier and stronger, like even potentially, stronger in athletic performance because estradiol, our main ovarian estrogen, is anabolic and improves performance and it's going to improve mood and it's going to. I mean, that would be very important for as part of the whole sex education picture. Instead of like almost from out of the gate, day one, it's like ovulation is something to be feared because you could become pregnant, so we need to shut it down. It's very much been considered expendable. The metaphor I often give is if we were to do the same for men, it would actually just be gobsmacking. So if you were to, obviously we know how important testosterone is for boys and men, and for women too. Of course, women have testosterone as well. But if you were to say to them, it's like, look, you know what? You don't need your testicular function until you're ready to make a baby. So we're gonna give you this medication to switch that off. And instead of testosterone, you're going to have this medication that's kind of like testosterone, but actually a little bit more like estrogen. And so it's going to affect your metabolism and your mood and everything. But don't worry about it because that's what everyone does. This has sort of been the paradigm this is the paradigm we've been in. And I mean, I've been speaking this way for decades, but as I get older, I'm just getting more and more like just astonished by what has actually happened. This really does feel like an emperor's new clothes situation where future generations are going to look back and think, what the heck were they doing? We look back at medicine from 70 years ago, like, wait, why were they doing that? Or they're like, why? So why did everyone think it was fine to just switch off women's hormones for decades? Yeah.
So tell me more about the why behind that. From your point of view, of course, oral contraceptives, or even, I guess they're not always oral, even the hormonal contraceptives, let's call it more generally, serve a purpose to help women prevent pregnancy when it's unwanted. But you're talking about the fact that there's some undesirable effects of that. What have you seen, or what are your chief concerns, and what does the science say about what we should be worried about?
Well, as you know, the science has been very slow on this. So, so just to acknowledge, it was a radical thing to legalize a medication that could prevent pregnancy. So we can't, I don't diminish that. I think that has been important for women, for society. Potentially, it's had some interesting effects on society. It's probably been actually quite a big event. It's really changed a lot of things. But in terms of like, the medication was invented, if you think about it this way, back in the
A disruptor,
50s,
really, in
essentially.
a
It
lot
was
of
came
ways.
to
Yeah.
market in the 60s, but it was invented before really there was much understanding of the menstrual cycle. I mean, hormones themselves had only been discovered a few decades before. Like they literally just discovered hormones and it's like, oh, let's decide how to, interfere with them, basically. Let's decide how to shut it down. So it wasn't, the new invention wasn't coming into a place of
Yeah.
knowledge. I always sort of speculate if it were first proposed today to use synthetic hormones in this way to shut down women's own hormonal system, I think it would be quite shocking. I think people would be like, that doesn't sound right. So, just to put it in context, we are 2025 now, and so there are other ways to avoid pregnancy. So we don't have time to go into all the different methods, but I'll just say there are some new male methods coming. There's it's called a vaso-occlusive. There's a new, essentially reversible vasectomy. That's an injection of a temporary gel into the vas deferens. I wrote about it years ago, but it's undergone its first level of clinical trials. They have to go through 2 or 3, however long. I think this latest speculation is it might come to market in 2027 or 2028. It was clinically trialed in Australia, which I love because obviously I'm connected to, even though I'm Canadian, I've been down under for a long time. So of course the Australians would step up and do the clinical trial on this. Of course they would. And so that's encouraging. So, questioning hormonal birth control does not have to mean questioning people's right and ability to to plan their own pregnancies. So in terms of science around what the side effects are, like there's been a lot of just head in the sand about this. So, we literally had decades. Like I've got an old quote from Margaret Atwood from one of her books in the 70s talking about the mood side effects and everyone reporting the mood side effects. That was like in 1972 or something. She wrote that. And then meanwhile, like it wasn't until 2016 that the needle moved at all in terms of any kind of acknowledgement that, yes, these contraceptive medications can negatively impact mood. That was all just considered. It was like, no, it's, you're just imagining it. And there was like just decades of just scientists and doctors saying, yeah, there's no proven link there. That has really changed. So I've just, I recently spoke with some people who were upset about a bit of pushback they'd had, criticizing the pill. I'm like, this is nothing. 10 years ago on Twitter, I could not, no one could put their head above the parapet and say, actually, progesterones can cause anxiety or increase the risk of depression. That was immediate slap down. That was immediate, they didn't use the word disinformation back then, but, that's not allowed. And then in 2016, there was the famous Lancet study it was a Danish study. I think it was the Lancet. I hope I've got the journal right. It was a very famous study. It was they looked at 1.1 million women, their medical records, and they found a small but significant trend to being prescribed antidepressants after all types of hormonal birth control, especially the progestin only ones. So that was pretty hard to ignore at that point. That was a watershed moment, actually, in this conversation. And of course, it's not just mood. There are a number of studies also suggesting that putting girls on hormonal birth control, especially the combined ones that really suppress estradiol, will prevent them from achieving peak bone density, which I know we want to touch on osteoporosis today. So I'll just say, achieving peak bone density as a young woman,
this is a foreshadowing of later conversations,
crucial.
Right?
It's hard, of course, because when you're talking to a 20-year-old, it's like it's hard to say what you do now is going to affect your bones when you're 75. I get the disconnect, and it's hard to have that conversation, but bone health actually starts in your teen years.
Well, I'm thankful for this conversation, and I come to it with a lot of curiosity because I think certainly I have a lot of respect for the benefits oral contraceptives have provided, and I also see that they're used and applied in ways that I don't think follows the therapeutic order, when it comes to me as a naturopathic doctor. Like they seem to be the cure for every ailment in women's health, right? You have any kind of hormonal abnormality. I had secondary amenorrhea or primary amenorrhea. I had like one period and then never got it when I was a teenager. And so when I went into the doctor, this is what led me to be a naturopath, that watershed moment. I remember going in and she was a really thoughtful nurse practitioner, women's health nurse practitioner. And she said, okay, well, we're going to give you like a pill to start your periods. And I wasn't looking for birth control. It wasn't sexually active. It was just like, let's get you cycling. And then I said, but what about when I want to have kids? Like, don't you want to know what's wrong? And she said, well, we have other medications we can use to help you when it's time to get pregnant. And to me, that was a real eye opener, because the way my brain always worked was, if there's a problem and this is something that my body should be doing, I want to understand why it's not doing it, and I want to fix the root problem. And that wasn't the response I got from that provider that day. And it was really impactful to me. And I see it applied in that way for a lot of heavy bleeding, menstrual irregularity, endometriosis, you name it. We use OCPs as a prescription for that. And I think we are oftentimes doing a disservice because we're not investigating the root cause. And now we're starting to understand a little bit more about root causes and what else we can do. But ultimately, it's really interesting. And I'm excited to talk about this on the podcast today and really talk about some of the longer term impacts. That's not the way that I think about it. I think more like, is this the best tool? Does it solve the problem, or is it just a Band-Aid fix?
Well, Band-Aid's the word. I mean, there's no question that contraceptive medication, I don't call them hormones because, I mean, they are technically, I mean, hormones in the broad sense, like they're hormone-like, but, they're not. I tend to use a different word for them because I think most people just assume they're hormones, like the actual estrogen and estradiol and progesterone in these medications. It's not, especially, although some types do have body identical estradiol, but none of them have progesterone. But yeah, so there's no question they can relieve some symptoms. They don't always, they're not a guarantee, but I mean, certainly they can suppress or mask symptoms associated with the menstrual cycle, which is not a surprise because they shut down the menstrual cycle. So one point that I will just touch on, because this is definitely when I'm speaking with my patients and my readers and interacting with people, the moment when people understand, what young women, especially young women, understand that the pill cannot regulate their menstrual cycle, it really is a moment of, for a lot of women, like just sort of shock and betrayal. Because I think the stats are that actually, of all the people who take, all the women who take a combined method, like a estrogen method of contraceptive medication with induced bleeds, of all the people who take those, 1 in 3 take it to regulate their cycle because of cycle irregularity. Now, as you know, it doesn't do that. I mean, a menstrual cycle is by definition a series of hormonal events, of which ovulation is the key event. So to just shut down the hormonal side of things completely and then induce like an induced uterine bleed for no reason is not meant, like there's no medical reason to bleed monthly on those methods. It's totally a smokescreen. And so when people really they're like, wait, what? So why am I having these monthly bleeds on the, like, what is even happening here? And has that fixed a problem? I mean, there can be an argument for inducing a bleed if someone who's, has a thickened uterine lining or something, and you need to induce bleeds somewhat occasionally. But this doesn't have to be monthly. The monthly was always just to mimic a natural cycle. Again, going back to the 50s and 60s, those scientists didn't think it could regulate the menstrual cycle. I mean, that narrative about regulating the menstrual cycle was actually put forward as a way to kind of get the pill legalized, because it was illegal.
Like a marketing.
Yeah, it was illegal
that's really interesting.
At that time.
Yeah.
Not that long ago, it wasn't legal to take a medication to avoid pregnancy. So, I mean, this is obviously progress has been made. And so they were like, wink, wink. It's not for that. It's just to like give you a healthy menstrual cycle. But they knew right from the get-go, they knew that's not what it was doing. It was always just kind of, well, everyone understands that's not real, but that's what we're going to say. And now that's what it's prescribed for. Like, like I said, the longer I go on with this, the more I'm just like, what have we been doing? This is such a strange thing to have come through. But I mean, just to also to put it in context, I mean, modern methods. So I will just here touch on the hormonal IUDs because they're obviously very popular. I think part of the swing away from combined estrogen methods of contraception are actually to swing to hormonal IUDs because they're popular. But one thing about them, they have their own set of side effects. Actually, they can affect mood and skin, and they can cause like breakouts and hair loss and stuff. But for what it's worth, they don't always suppress ovulation. So they can avoid pregnancy, lighten flow, achieve some of the goals. But they depending on the dose of the medication, like the brand, like the type, the age of the woman, and how long since insertion, that will sort of depend on how much progesterone she's being exposed to. And some women can ovulate through
and
that.
their body
So
weight as well, right?
They could
The
be
patient's
cycling.
body weight. Yeah.
Yeah. All various factors. So some women can cycle through that. And even if, because the uterine lining has been suppressed to the point that they might not see bleeds, but they could still be cycling. It's actually a very unusual situation. It's one of the only times when you can cycle without having a menstrual bleed. By cycle, I mean ovulate regularly. So women can track that by tracking body temperatures potentially. So just to compare and contrast the two things. So with combined methods, like the combined pill, patch, NuvaRing, things like that, women are bleeding, but not cycling, which is pointless. With the hormonal IUD, you can cycle but not bleed. So it's actually of the two, it's the preferable one. And that's not to say that that hormonal IUDs they're not without their own side effects, but they are. A number of my patients do use hormonal IUDs, and I get it. Like, they can dramatically reduce flow, and at least they're still making, in many cases, some of their, enough estradiol and progesterone to promote general health, to promote metabolic reserve and good bone density and things like that.
So let's talk about this and talk about when you're thinking about the hormones and why they're so important.
Yeah.
Why is a menstrual cycle? Why is the ovarian timed production of estradiol? What are like the top 3 things you think this is really important because it helps with? I mean, I know there's a million things on that.
We could do a little love poem to estradiol right now.
Let's hear it.
Let's hear it. Like a little sonnet. I mean, it's amazing, obviously. Like it's supports mitochondria, it's anabolic, it reduces cardiovascular risk via several mechanisms. I mean, there's a lot of research to suggest that, the estradiol exposure we get during our reproductive years significantly reduces women's risk of heart disease, insulin resistance. It's good for the brain. It's like good for bone health. What would you add to that, Jaclyn?
Well, I think you have
all the many benefits
like energy
of estradiol.
and mood stabilization. Then you have bone protection. There's like so many
dopamine,
health.
serotonin.
There's a lot of things
Yeah, it's pretty great. And like I said, the synthetic estrogen in the pill is not as strong. It's not as good in those. It doesn't deliver the same benefits. It does deliver some. It has some of the same benefits, but not to the extent, particularly around metabolic health. So it's pretty clear that the right amount of estradiol improves metabolic health, insulin sensitivity, whereas ethinyl estradiol does seem to have some negative metabolic effects, which is sort of a compare and contrast. And then, of course, there's progesterone, which deserves its own, love poem. It has all, many benefits as well. I think I mentioned some of them earlier. Primarily, many things, but it metabolizes to allopregnanolone, which is the brain is expecting to have. I mean, let's face it. From an evolutionary perspective, the brain is expecting to have allopregnanolone in women. Like it's expecting it to have it every cycle, huge amounts with pregnancy. And to just turn off the tap on that neurosteroid completely for decades is having an impact. I mean, I think we're starting to know details like women on hormonal birth control have different brain structures compared to women who cycle naturally. I mean, there's could be lots of reasons for that, but I think allopregnanolone is one of them. Yeah, and progesterone, it's also, I mentioned it's immune modulating, so it can help to reduce the risk of certain autoimmune diseases. And yeah, I mean, I'm a big fan of progesterone as well. I call it the Cinderella hormone. It's the one that kind of didn't get invited to the party. It got really left out of the party. Like, you know, estrogen, at least even conventionally, has had some accolades, but progesterone is like, oh, it's disposable. So we don't really need it.
Yeah.
Um,
It's funny. Internally, we kind of call it the princess hormone
oh
because
yeah,
everybody always wants to talk about progesterone. And I
right.
think estrogen actually doesn't get enough of the spotlight. I'm like, estrogen's kind of like our Beyonce of hormones. Like, you really want that.
It's
You
true.
need it. But it gets a little bit maligned with, the progesterone princess in the room.
Well, that's just from a natural health
Yeah,
perspective. So
exactly.
this is, yeah, I mean, this is coming at it through our field. I love it, Beyonce. I call it, in my book, I call it the queen hormone. I mean, there's no question. I mean, estradiol is amazing. I won't swear, but like, it's like, yeah, it is amazing. And it has gone through, certainly in natural health, there's been this, I don't actually use the word estrogen dominance because for various reasons, which I've written about, or we can chat about it a bit, but
We can talk about it. Let's talk about that. I completely agree. I
yeah.
think it's
I,
not a scientific
It's
concept.
not a
So,
term. It's not a medical term.
right.
It's primarily, there's a couple things going on with it. I think we'll just talk about estrogen a little bit. And I mean, I think mostly it's used to describe unopposed estrogen. So obviously when cycles, which are super common, anovulatory cycles or cycles where progesterone is not kicking in properly. And so I'm 100% on board with that. Like, I think that women do need both. They need that progesterone phase to counterbalance estrogen for lots of reasons. I mean, breast health and various things. So there's no question that having all estrogen and no progesterone is not ideal, but I still don't use the word estrogen dominance because it's just too nebulous, it's too vague. It also kind of it has a negative built-in connotation that estrogen's bad, which, as we've determined, it's not. Also, I think some women do experience quite negative symptoms from their estrogen peaks, and so I think that's
Mm,
partly what that term is invoked to describe. And I think some of that is some women get quite a strong histamine reaction to estrogen, and that's really to do with immune system. Through the naturopathic lens, this is about, considering the body as a whole and looking at, how our immune function, our immune situation really does quite strongly
mm.
influence how we respond to the normal ups and downs of both estrogen and progesterone, actually. So I think that's partly where it is. But the other thing, the development on the scene, is that we went through a time when, especially in natural medicine, where estrogen was kind of considered bad, which I never agreed with. In fact, I have I think it's like 2011 blog post called "In Defense of Estrogen."
Hmm.
It's like, come on now, we need to. I think I even like the image as a queen. I'm like, this is an amazing hormone. Um, but then we've gone into, of course, we're in the perimenopause space now, where there's been this people trying to it's a reaction to the
Right.
decades where women were too afraid to take estrogen in
Hmm.
menopause, and which was not good. That sort of it's a whole story. But so then there's been this resurgence of estrogen is super beneficial. Now there's like in certain circles, depending on who you're talking to, estrogen can do no wrong. Like, it can fix everything. It's like it fixes, ADHD. It fixes, like, bone and health and mood and just whatever's going on. Is like, take some estrogen to fix it. This is and so but the weird disconnect about that is, like, that's all around perimenopause and menopause. So then there's this sort of been this narrative, which I find very jarring. Somehow, from the age of 45, estrogen is amazing and you can't live without it and you must take it. Um, to be fair, I take estrogen, so I'm not saying you shouldn't take estrogen. But then at the same time, there's this
Mm.
still relic of, yeah, but before that, when you're in your 20s and 30s, it's fine to shut it all down with hormonal birth control. I mean, to be clear, most methods of hormonal birth control switch off estradiol. And
Mm.
so why, I'm just like, well, why is estradiol important in your 40s but not in your 20s or your teens? Like, so I mean, obviously it's important at every phase of life. And we do with menopause, through my evolutionary biology lens, menopause is not an accident of living too long. We did
Right.
evolve, actually, menopause, and we did evolve to have a lower estrogen phase of life. It's not zero estrogen, actually. There's still quite a lot of estrogen around. Yeah.
What's the evolutionary benefit of menopause from your from your background?
Well, you're giving me an opportunity to talk about all my favorite things, which is nice. So, this is all come. If people want a solid reference for this, there's a book called The Slow Moon Climbs that written by a historian, sort of anthropologist, and I was heavily influenced by that book. It had a big impact on my perimenopause book, Hormone Repair Manual, and she builds the case. It's quite a dense book, but I love that sort of thing with my science background. She builds the case. It's actually not so much that menopause evolved, it's that a longer human lifespan evolved past reproductive capacity. So I think it's possible. I mean, she talks about the different aspects, but I think it's possible our ovaries can only keep going to 45. Like that's possibly just a thing. But yeah, although there's little glimmers of that there, there could theoretically be ovarian stem cells,
right? So there's definitely.
Yes. I mean, I think most people can agree by 45 though, unless some future intervention can change that, the ovaries are pretty much done. But what the way evolutionary biologists see it is what's weird. It's not weird that we stop by 45. That's probably hardwired. What's weird is that we keep living for another 40 years. And we always have. By always, I mean probably as long as we've been human. Like, it's not new. The narrative that we all used to die by 45 is incorrect. That was a statistical thing. Like, back in the day when you had 1 in 2 babies dying, unfortunately, it's like, yeah, but if you look back in the fossil record and even just historical record in cemeteries, there are women getting to 80 or 90 years old. I mean, that's not new. They were lucky to escape child infection and death in childbirth and all the things. Like it was unusual to get to that age, but the biological women could always get there. And so in the book, The Slow Moon Climbs, she builds the case that, which is actually really fascinating, that a longer human lifespan for both sexes evolved or was selected for because women in their post-reproductive years, in their 50s, 60s, and 70s, are so incredibly beneficial to the family group, like just crazy off the charts, that those long-lived genes are going to be selected for, because obviously then she's around and then her offspring who have those long-lived genes are around. And she draws on all sorts of evidence, but like primarily you look around modern day forager people and they have these numbers, like the people gathering the most food and kind of holding it all together and really like getting it done are the women in their 50s, 60s, and 70s. Like they gather more food than any other demographic. The men are sitting around the fire telling stories, and the women are like, let's, get this sorted. And the analogy, there's a metaphor with, or not metaphor, it's a parallel. Of course, killer whales or orcas have a similar structure. Right. And if you really dig down, and I won't spend too much time on this because obviously I'm very excited about this topic, but if you really dig down, what actually menopause evolves, or a longer post-reproductive lifespan evolves, when adult sons stay with their mothers. So it's like at some point the woman actually kind of switches to being kind of vicariously male because she's promoting the reproductive success of her sons and possibly daughters as well. Although in orcas, one of the things the matriarchs do is try to prevent their male sons from fighting so much. I just love that.
Gosh, that's not true to life as a mom with 4 boys at home.
Okay, there you go. So yeah, that's the basic argument. And so this narrative that menopause is an accident of living too long, I really like. There's very few things out there that, because I mean I've heard it all, but like when I hear that narrative on social media, I'm just like my back goes up. That's
very
incorrect.
little in science is accidents, right?
We'll be right back. If you're a clinician seeing more women in their late 30s to early 50s who don't quite fit the typical menopause profile, but are clearly not feeling like themselves, this is for you. We're thrilled to announce the release of our new course, Perimenopause Management, This is a comprehensive, evidence-informed course designed to help you identify and address hormonal shifts before your patients reach menopause. You'll get clinical tools, treatment strategies, and real-world case examples to elevate how you support women through this often overlooked transition. Make sure you're a registered Dutch provider to gain access to this free course. Visit DutchTest.com to become one today. We're back with the Dutch Podcast.
I want to switch gears and talk a little bit about some of the reasons why hormones are so important and some of the more specific applications. So let's start by talking a little bit about bone health and osteoporosis. And so I think most people are aware that estrogen is really important for bone growth. But you talk about a lot of other hormones that we don't always think about besides estrogen. And other factors that are overlooked, especially during perimenopause, other factors that are overlooked as kind of a piece of the puzzle when it comes to osteoporosis. Can you start by just giving us like kind of the overview?
So let's do a little mini masterclass on bone health. I'm sure you can chime in here with various things. Two important points to understand about bone health. One, it's a long-term project. It starts in the teen years, as I mentioned earlier, and that achieving peak bone density is huge. It's actually difficult to overstate how important that is. And that women would have the strongest bones they're ever going to have by about 25 or 30 years old. And the second point about bone health is that bone is living dynamic tissue. It is affected by so many things. It's also bone tissue, bone cells themselves, especially the osteoclasts, are very cousins of immune cells. So the immune system has a huge role in bone health, which is one of the reasons that immune conditions like celiac disease can have such a negative, corrosive effect on bone health. So it really is, everything in health from a naturopathic perspective is troubleshooting the whole picture, but bone health truly is. Like if there's an underlying inflammatory condition, then that needs to be addressed. There's several medications that can quite negatively affect bone, and I'll just mention them while I'm thinking about them. One is the PPIs, the proton pump inhibitors. It was always, the bone risk was known with those. It was like, oh, it's because they impair absorption of minerals. It's more than that. They're doing something to the actual bone cells, the dynamics of bone cycling and resorption and deposition. And also SSRIs, there's been for a while a signal in the research suggesting that SSRI antidepressants can have a negative effect on bone, probably because of the effect of serotonin directly, which is quite troubling. It's an example of all the details that we sort of collectively kind of hope are going to be okay, and then we find out, but in terms of hormones, so there's all the hormones affect bones. So estradiol is quite famous because it slows the osteoclasts, or the cells that are chewing up bone. And it does that. There's no question about that. It's very important for bone health. But on the other side of things, androgens or testosterone is quite important for both men and women. It stimulates osteoblasts, the cells that deposit bone. The other hormone that stimulates osteoblasts is progesterone. And so progesterone has been also off the radar, another example of the Cinderella hormone. It's just been forgotten about in the bone conversation. But my close colleague, Professor Jaclyn Smeaton, who's a reproductive endocrinologist in Canada, some of your listeners probably have heard of her. She's done a number of papers on the role of progesterone in bone health. And so she's essentially established the fact that having regular natural ovulatory cycles where you make progesterone helps to build bone through life. And also it also gives a sort of another tool potentially, because progesterone can, for those women who maybe can't take estrogen once they reach the point of perimenopause, menopause, and they're reaching the point of faster bone loss, that progesterone can be something to consider there. So can androgens. I'll just give a plug for DHEA. I don't know if you remember, like about 15 years ago, DHEA was really, it was on the radar as a potential treatment for some of the symptoms of perimenopause, menopause, for improving bone health. And then it just got dropped. I guess it must have had some negative studies where they decided to forget about it. But I actually still think DHEA is quite an interesting hormone.
Yeah. My first time using it was actually, I was working in school on like a shift for HIV positive men, and it was like profoundly impactful for their quality of life. I mean, now we've come so long, so far in the treatment of HIV, but it was an amazing natural tool that was really improving sleep, cognition, energy levels. It was really very impactful. But you're right, we still talk about it a lot at Dutch. We talk about it a lot because I do think, probably like you, there's still so many benefits. And especially with testosterone being a DEA restricted drug, DHEA is a great precursor that can help with that kind of building of androgens in women who are low.
I agree. And I actually think it's a better option. I mean, just to segue a little bit into, the question of whether to supplement androgens with menopause or post-menopause. I mean, I think if you're going to, I actually think DHEA is a better option through my lens. One of the problems with testosterone is that, I mean, it's great. Obviously, it depends on if you dose it at the right amount and properly balanced by estradiol and progesterone, it can be okay. But one thing to have on people should remember about testosterone in women in the female body is that any degree of testosterone excess will promote visceral fat and insulin resistance. That the literature around that is really quite clear. So, I mean, that's, in terms of the big, when we consider how important metabolic health is and how widespread insulin resistance is, I sort of feel like prescribing testosterone should be done very carefully. But
that's interesting. Does it do the same in men?
No. So as you know, I mean, men actually, again, it's all context dependent.
Usually it's associated with a lower body fat.
Exactly. So men, in the male body, testosterone will, through different mechanisms, improve insulin sensitivity, improve muscle mass. And that's one of the ways that it obviously improves metabolic health. But in women, we have a different reaction. I mean, we can see that it's in the literature pretty strongly. So we know that obviously the androgen excess associated with polycystic ovary syndrome promotes insulin resistance. It becomes a vicious cycle because then insulin resistance promotes androgens as well. In my perimenopause book, I have a short section on the relative androgen dominance of the later phases of perimenopause. Once progesterone and then estradiol drop away, then androgens start to shine through, especially when SHBG goes down, and then women are exposed to more testosterone with menopause, post-menopause. That's why, I mean, it's just obvious, right? That's why we get more facial hair. You get the thickening. In fact, that sort of visceral fat is also called androgenic fat, or this is an androgen shape to have that kind of square waist. And I mean, I've written quite a bit about this, but this is where I think, but just back to the point of androgens are also important for bone health. Insulin, I mentioned insulin resistance. It can be very corrosive to bone health, partly because it promotes what the researchers call anabolic resistance in the bone. So because insulin is actually normal, insulin is also a growth hormone. It's important for normal signaling of bone growth, but when there's resistance, that fails. And so we do, I mean, because of the growing awareness of the impact of metabolic health on everything, you'll hear different conditions called, type 3 diabetes. So, dementia potentially has a strong component of metabolic dysfunction. I've heard, osteoporosis called the same thing. So improving metabolic health can make a big difference for bone health.
So you mentioned this earlier, but like when you talk to women who are in their 30s and 40s, even younger, how can we encourage women to more actively take steps to improve or protect their bone health? What are the ways that you found to help people understand what matters? And I totally get it. It feels like that only happens to elderly people, and I'm not even close to that. I don't have to worry about it.
I know. Yeah, and of all the tissues in the body, right, bone has the longest story arc. You know what I mean?
Like a slow film. It's like a slow art film. It's not your action flick, right?
Yeah, it's very slow art film that takes 80 years. You could change the nervous system. I mean, obviously things, many tissues can be imprinted, or they can have something that, got set up early and can take a while to change. But I mean, I just feel like other tissues like the nervous system and the immune system are more dynamic, and the gut certainly is pretty dynamic and can change. But bones, that story of your bones in your 40s is just a continuation of the story of the bones in your 20s. And in terms of your question, like, how do you inspire women to really care about their bones, young women? My feeling, I mean, after decades of talking to women about it, I don't even try really. I just focus on what their current proximate concerns are. So I'll be like, you can definitely frame it as, you need estradiol and progesterone for physical fitness, for good muscle health and metabolic health in the moment, and for mood and things like that. I just think that's probably a bigger motivator. What do you think? I mean, have you had any luck talking to younger people about, preventing a condition that's going to happen in 50 years? Yeah.
Yeah, no, I think I take the same approach you do, which is, and I think about this too, because like with fertility in
Yeah.
men,
Yeah.
the pre-pubertal period, like ages 10 to 15, 10 to 14, is like another critical period for their fertility, where you
Interesting.
need to like avoid toxins, avoid, cell phone radiation and
Yeah.
all the radiation, eating clean, eating well. It's probably the hardest group to try to get to have healthy behaviors. I mean, they live
Yeah.
on like burritos and soda, right? As much as possible. So same kind of thing. I think unless you have lived it, like you have a parent who had a fall, fractured a hip, has osteoporosis, it's hard to make it feel real for you. So I
Yeah.
think the same, like focusing on what's in front of them and really around maybe bringing it back to the importance of that healthy menstrual cycle and why all the hormones are so beneficial with the side effect of healthy bones into your old age. But I think
Yeah.
the other pieces of it, like adding weighted vests, are very popular right now. And I think that's another benefit to bone.
Sure.
There's things that you can do today that are trending or that are more, I guess, interesting than just prevention of something that feels so
Yeah.
far off.
Yeah. And one thing about actually just things are changing in a good way. So it's not that long ago, the culture in elite sport was that girls lose their period when they're athletes, and that's fine. That's normal. And so there's been a lot of people working to change that behind the scenes, just really pushing like it's not okay to lose your period. It's not okay from a, health perspective, from an immediate health perspective, and obviously from a longer term bone health perspective. And just to be clear, I mean, one thing that's really changed in that space is even 10 years ago, like there was this idea that, well, you just take the pill and it'll fix it. But actually what we know and I'm pretty confident about this, the oral contraceptive pill does not protect bones or help bones in young girls the way it's not as good as having a period. And also if they're really in a situation where they just can't get their period back, the interim measure now, at least in the UK and down here, I don't know what it's like in the US, but the gold standard practice is actually body identical hormone therapy for those young girls, young women. So that would be proper estradiol patch, Eutrogestin, Prometrium, proper progesterone. So that's been a big shift. And that's sort of part of the growing awareness that actually, surprise, surprise, young women need hormones. And yeah, so that hopefully will lead to future improvements with bone health. Yeah, and nutrition, and obviously nutrition as well. So just being fully nourished with everything, including protein, not just calcium, right? Like the bones aren't just a repository of calcium. Like they're super dynamic, so they need enough protein. They need enough. I'll just give a plug to. I mean, everyone knows vitamin D, but vitamin K2 is really important for bone health, and zinc, and all the things.
Yeah. Good. Great. I think that's really helpful. The last topic I really wanted to dive into today is around
Yeah,
insulin resistance, which you've talked about a
yeah,
couple of times, but you've been talking more about metabolic health and insulin resistance in
yeah.
women. And insulin is a
I
hormone.
know.
Our blood sugar regulation is done by hormones. And I think I love the way that you embrace this
Yeah.
as a kind of in the female hormone conversation, because I think there's not a lot of people who are doing that. So why are you including that in this kind of female hormone conversation? And tell us a little bit about what
Yeah.
is important about that.
Yeah. Great question. So my third book is about metabolism repair for women, is all about insulin resistance. And in the introduction, I talk about why does a women's health expert veer into metabolic health? Well, I consider it actually going deeper because, as you know, like metabolic health, which is like quite a broad term, I realize that, but it's so central to everything. It's very central to a lot of aspects of women's health as well, like being able to ovulate regularly. And I've tried to reframe it as insulin resistance it is a hormonal condition. I think when you put it in those terms, it sort of it sort of makes a bit more sense to people and one of the things I'm trying to, in future presentations and interviews, I'm trying to sort of shake off the old association with blood sugar, because that's just one small part of it. Like, insulin does help to regulate blood sugar, clearly. I mean, it's one of its big jobs, but it's not its only job. And insulin as a hormone is quite unique in that it interacts with almost every tissue in the body. And the main feature of insulin resistance is having chronically elevated insulin, and that is not good. So we just talked about how that's not good for the bone health. That can create anabolic resistance in the bone. It definitely can create energy deficiency in the brain. One of the things about chronically elevated insulin is that it directly impairs the body's ability to access body fat for energy. So it can create this situation where you're not only gaining weight, but you can't even tap into your own fat stores to have the energy you need between meals. So you kind of just get locked into carb burning. You get locked into this, cycle of, in many cases, low blood sugar and needing to, eat a granola bar just to get through the afternoon. And it's that's not a pleasant place to be for people. And with the extra layer of, if you think about those symptoms, that being hungry all the time and getting drops in blood sugar, if you think about it, those are symptoms of a hormonal condition, insulin resistance. But most people just, especially women, just internalize that as, oh, that's just me. I'm a, bad person. I don't have willpower. I can't eat what I'm supposed to. And so my third book was trying to reposition that and trying to I feel very strongly that the collective shift to insulin resistance that's happened over the last 70 years, and it's astronomical. Like, it's really bad.
It's staggering.
It's staggering.
Yeah.
That's the right word. It's absolutely staggering. That is not people's fault. Through no scientific lens is that people's fault. Like, scientists know this. It's like the food environment changed.
And the environmental toxins are
Plus
absolutely wrecking our metabolism.
Yeah. So it's a combination exactly. So in fact, one study I quote in the book, or cite in the book, estimated that probably about 15 to 20% of the epidemic or the epidemic and metabolic dysfunction is directly attributable to environmental toxins. So clearly that's not people's fault.
I'm actually surprised it's so low, because the data, I wonder if that's more about your own individual exposure. Because if you look at exposure during pregnancy, the outcomes of the offspring are huge. Like, I just remember the epigenetic study. It was in agouti mice. So this is not a human study, but there were two mice, two groups of mice, genetically identical. One was exposed to folic acid, the other was not, and they were both in a BPA containing environment. And one of them, the mouse that got folic acid, the offspring did not develop insulin resistance and the body, obesity and things like that. The mice that didn't get that nutrient did. When the mother, the offspring did. Yeah. And it's really fascinating when you look at nutrient sufficiency and exposure to endocrine disrupting compounds and the impact on metabolic health of offspring long term. It's pretty scary.
It is. And it's good that you bring up the epigenetic aspect. I'll just touch on that briefly. Obviously, I assume our listeners all know what that means. These inheritable, exposures that are passed on. That's a big, so that's not just from environmental toxins, that'll be from our food environment as well, various genes being up and down, regulated up and down, passed on. That's why, again, it's staggering, the epidemic of metabolic dysfunction / insulin resistance is amplifying every generation, because it's being passed on. It's epigenetics and it's in utero sort of programming. And so now you have kids with fatty liver disease and, quite advanced insulin resistance, which was unheard of, like even 40 or 50 years ago. Even those of us in the 70s who ate, my diet wasn't that bad, but Oreo cookies. And even the kids, kids were eating a lot of junk food back then too, but they weren't succumbing, they weren't developing these complications the way kids are now. And a lot of that's from the epigenetics. So it's going to take generations to unwind this. There's not an easy fix, which it's hard to write a book about something for which there's not an easy fix.
Because you don't have that plan in your last chapter. There's no appendix with a supplement regime to fix it
No.
all. Yeah.
It's you'll be fine in 4 weeks. It's all gonna, no, it's it is. And there's a deep, which I try to acknowledge in the book, it's deeply unfair. It's deeply, deeply unfair how some people, through various luck in their, generational exposures and genetics to some extent, some people have been less vulnerable to this onslaught than other people. And yet, they're made to believe it's they're doing everything right. But is it that, or is they just got lucky? And, some people are 4 or 5 generations in to being pushed deeper and deeper into insulin resistance. It's very unfair. And it's quite heartbreaking actually. But it doesn't mean there's nothing to be done. There's still ways to, start to reclaim our birthright of a healthy metabolism and healthy insulin sensitivity.
Yeah. Well, I want to end on just one question, which is around testing, because of course that's what we love and do at the Dutch Test.
Right.
And
yes.
So bringing it back to where we started from with kind of this desire to understand our hormones, or need to really understand our hormones. Can you talk a little bit about the role that lab testing has in that for women? Do you see, obviously we can track our menstrual patterns and that's foundational, but are there things that you can pick up on lab testing that you can see that you're headed towards dysfunction before things get too severe? Or is there any benefit to that from your point of view?
I do the lab testing I do a lot of. Keeping in mind, so my patient population is not in New Zealand, is middle income. I am very conscious of testing costs for sort of been, I think over the years, I've been doing it, trying to stick with some of the less expensive testing. So my starting place is usually some of the standard parameters. I'll give you some examples. I do quite a bit of testing around insulin resistance, which we just spoke about. So I'm not just testing insulin or HOMA-IR index. That's a possibility, but also looking at things like fasting triglycerides, ALT, like an elevated ALT when the other liver markers are normal is a pretty classic sign of insulin resistance. In women, it should be less than 19. The ratio between triglycerides and HDL, there are all some ways, we can use some pretty simple markers to start to gain a picture of metabolic health on that side of things. And then I also do thyroid. We haven't even touched on thyroid, but thyroid's hugely important for women in particular. And as particularly thyroid autoimmunity. So I almost screen for thyroid antibodies, not every single case, but I actually find TPO antibodies, autoantibodies, quite helpful. It paints the picture of if they're positive, it doesn't necessarily mean they have Hashimoto's full blown, but they have an autoimmune tendency picture that can imply something about, how important it is for them to avoid gluten, for example. I often I screen for celiac serology, celiac genotype. I look at iron studies and B12 and some of the ones that are unfortunately missed. And and I'll just say a word on B12. I think there's an optimal range of the units would be the same down here, but I think B12 should be greater than 300. I think there's a lot of people walking around there with subclinical B12 deficiency, and that's a big player in mood, symptoms, migraines, dementia risk, things like that.
Fabulous.
Yeah.
Well, we've covered a lot today.
We have.
I've learned a lot. It's been really wonderful to talk with you. So I really appreciate you taking the time and joining us.
Yeah, I always love talking with fellow naturopathic doctors. So we're a particular tribe, and I can always tell when I'm speaking with one. It's great. It's been great to meet you.
Thank you.
Yeah.
Great to meet you as well. And if people want to learn more about you, what are the best places for them to like visit your website, social media, etc.?
Yeah, I'm super easy to find. My website is larabriden.com and all my social media is at Lara Briden.
Fabulous.
Yeah, and I've got the 3 books. I'll just
Thank
quickly
you.
say Period Repair Manual, Hormone Repair Manual, and Metabolism Repair for Women.
Great. We'll make sure we link to those in the show notes.
Right.
Thank you
Thanks.
so much, Dr. Briden, for joining me today.
Yeah,
Thanks,
take care.
everyone.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.